For our next speaker, I'd like to welcome back Dr. Ali Salim, and he's going to talk to us about ARDS in 2015, I believe.
Well, it's a little tough to talk about ARDS after that excellent talk, but I'll try to keep everyone interested, at least for a little while. So I'm going to try to just give a review about what's new in ARDS. Again, I have absolutely nothing to disclose. And the way I want to approach this, I'm going to first summarize sort of the things that we already know, what's not new, and then I'll go into sort of what's new in the past couple of years in terms of the management of ARDS. So I'll start off with what's not new, well studied. I think we all know, we know it's an inflammatory process that's from an insult, and that insult ranges from a number of factors, and those insults are actually very well studied. With respect to trauma, the insults are also very well known. Whether it's fractures, fat embolism, aspirations, sepsis, etc. We'll talk about that. We're starting to see a decreasing incidence of ARDS, especially with our trauma patients, and for a number of reasons. Mortality, we know a lot about the mortality with ARDS, and if this is just looking at the NIH-sponsored trials in terms of ARDS, we see from the beginning in the late 90s the mortality was 40%, and more recently with more recent trials the mortality is actually halved to about 20%. It's very well known. And specific with trauma, I think it is very unique, is we know that patients who have ARDS have an increased risk in death. The mortality rises. But as we sort of drill down into that, we find that it's not the ARDS that's actually increasing mortality. It's probably the injury severity factor. So like more and more we see that ARDS actually doesn't by itself increase mortality in trauma patients. It's actually the overall injury burden, which is actually very different from non-trauma patients. In terms of treatment is very well established. We want to treat the underlying cause. Remember that it's an insult that causes an inflammatory process that leads to this ARDS. And then there's supportive care, mechanical ventilation. Now we always talk about supportive care, but what really is supportive care? And all that is really just good ICU care. So basically you want to prevent nosocomial infections, you want to decrease the risk of your DVT, prevent GI bleed, and provide adequate nutrition. So again, it's just really good, appropriate ICU care. Also in terms of fluids, this is another NIH study, well done, prospective randomized studies that just shows you how much fluid you need to give in these patients with ARDS. And really you want to have a conservative fluid management strategy after the patient's been resuscitated over that initial insult. Then you want to make sure that they're either euvolemic or maybe a little bit hypovolemic as well. And what about mechanical ventilation? This is sort of the mainstay of treatment. And we know a lot about mechanical ventilation in terms of ARDS. We know that we want to avoid ventilator-induced lung injury. And what is that? It's really this. It's that barotrauma, volute trauma, and atelect trauma. So we know that when you have high pressures, high volumes, that causes the stretching of the alveoli, increases the inflammatory response, actually worsens the ventilatory or the pulmonary damage. So it's actually the vent. When we learned is that not only is there an insult that causes an inflammatory process, what we were doing initially in terms of the vent management was actually exacerbating the lung injury. So we know a lot about that, and we know that what we need to do to prevent this ventilator-induced lung injury, or the villi, is basically using low tidal volume. And another way of saying low tidal volume is saying protective lung ventilation. And this was the landmark study I think that we all know about, is the ARDS study that probably is the first time it showed some benefit in terms of treating patients with ARDS. And it was basically high tidal volume, or at that time, which was normal tidal volume, about 12 cc's per kilo versus 6 cc's per kilo, and found a significant decrease in mortality in those patients that were ventilated with 6 cc's per kilo. So again, 39% versus 31%. Just as an aside, again, I was trying to bring it back to trauma. There was only very few patients in that original trial that included trauma patients, but there was really no mortality benefit in terms of low or high tidal volume. Again, partly because there weren't that many patients, and then also partly maybe it's because of that whole idea that the ARDS doesn't actually increase mortality in trauma patients. Now, there's been a number of trials over the past few years that have looked at low tidal volume ventilation. It's about 6 trials in all, and this is a Cochrane meta-analysis that showed that if you put them all together, there's a significant mortality benefit when you use low tidal volume ventilation, such that low tidal volume ventilation obviously is the standard of care, so that really no other trials are being performed in terms of seeing whether low tidal volume should be used in our patients. And this is something also interesting that we see in terms of ARDS. I alluded to it with the initial, if you look at all the NIH trials of how the mortality has decreased. So overall, even if you look at non-NIH trials, the mortality for ARDS has significantly decreased over the past few years. And also something interesting is the incidence of ARDS seems to be decreasing as well. We see that a lot in our trauma patients. And there's been a lot of thought in terms of why that is. I think clearly in terms of our resuscitation, the way we're treating or resuscitating patients has definitely changed. Blood, we're not using it as much. Blood is utilized a little better than it has been in the past. And there's this thought that maybe the way we're actually ventilating patients in the ICU is actually contributing to this decrease in incidence of ARDS. And this was this study that came out of LA County. If you sort of track the incidence of ARDS with the tidal volumes, you see that it sort of correlates. The lower the tidal volumes have been going, the lower the incidence of ARDS. And there's been a number of studies that have actually looked at risk factors for ARDS. And one of the interesting things that they find is that one of the main risk factors for developing ARDS is actually using large tidal volumes. Just a few years ago, was a prospective randomized trial that looked at patients who don't have ARDS or acute lung injury, and they basically randomized to higher tidal volumes, 10 cc's versus low 6 cc's. They actually stopped the study early because there was a significant increase in lung injury in the patients that were ventilated with higher tidal volumes. And if you look, there's actually been a number of studies that have come out that are sort of looked at when you ventilate non-ARDS patients with lower tidal volumes. So there's something there about ventilating patients with lower tidal volumes. In fact, our anesthesia colleagues actually are doing it now in the operating rooms as well. Now, how low is low? What's the appropriate volume for tidal volume? If you sort of map out the mortality and tidal volume, we know that the higher the tidal volume, the higher the mortality. Also, the lower the tidal volume. If you get too low, it also increases mortality because of hypoxemia, atelectasis, et cetera. So there's definitely a sweet spot in terms of what the tidal volume should be. We sort of say it's 6 cc's, but some people are sort of pushing the envelope and saying, what about 4 cc's? If 6 cc's is good, why not 4 cc's? And there's some trials that are underway that are looking at what that sweet spot for tidal volume should be. Now, that's really a summary of what's not new. What's new? And these are sort of some studies that have come out probably in the past couple of years that have actually sort of changed some of the ways that we treat our patients with ARDS. One of the things that have changed over the past few years is the definition. In 1994, is the classic consensus conference came out with the original definition of acute lung injury and ARDS, and that was based on these criteria that you see here. But there's been another consensus conference over the past couple of years, and they came out with the Berlin definition, and it's very similar in some ways. It looks at timing, that basically if there's an insult within a week and you develop this respiratory failure, that's part of it. The chest imaging, you have to have the bilateral pulmonary infiltrates. You have to have a non-cardiogenic source, and the initial consensus criteria said that you had to use a SWAN or CVP. Now, according to the Berlin definition, they advocate the use of using an echo or something like that. And then the most important difference is the idea of separating out the severity of ARDS, looking at the oxygenation. So it's mild, moderate, and severe. So they've gone away with acute lung injury. Acute lung injury is no longer. Now it's either mild, moderate, and severe. And when they try to validate this, they see that the majority of patients actually have moderate ARDS, but definitely the mortality increases along the severity of the ARDS. What else is new? So the idea of prone positioning. I remember when I was a fellow in LA, we used to try proning patients, and it'd take act of the whole ICU getting together to take these patients and turn them over, and we realized that, it really wasn't doing any good. It may improve the oxygenation, but it felt like, it was increasing the complications. It really wasn't that helpful because the mortality wasn't changing. So now, fast forward to now we're revisiting the idea of prone ventilation. And this was a study that came out a couple of years ago that's randomized 230 or so patients into proning versus supine. What was interesting was the proning. It was actually done for a prolonged period of time. So they proned patients for 28 days, about 16 hours per day, consecutive hours. And then they had criteria of when they can actually put them supine and when they can actually stop the proning. And they found a significant improvement in outcomes when those patients that were proned. So if you look at 28 days versus 90 days, vent-free days, and cardiac arrest was actually higher in the group that was supine, which was interesting. But if they looked at all other complications, there was no difference. And they concluded that early application of prolonged proning, which is about 16 hours, actually improves outcomes. The problem was that the hospitals that utilized the proning were actually experienced in proning. So to be a center to participate in the study, you had to have experience of proning. And most of the hospitals at least proned for like 5 years before they actually entered the study. So they really had experience. In fact, that was their standard of care in terms of managing these patients. But it's still something that people, we're actually starting to look into whether we should actually start proning in our ICU. The next, I think, important study that's come out is the use of neuromuscular blockade. And again, when I was a fellow, we were paralyzing everyone. And then we started realizing that there were actually detrimental effects for paralyzing patients, so we moved away from it. But now, fast forward to now we're starting to look at the role of paralyzing patients with severe ARDS. And this was another randomized prospective trial, almost 200 patients in both arms, and they paralyzed patients for 48 hours, just the initial 48 hours, and then that was it, and compared that to placebo. And again, the groups that were paralyzed had a significant improvement in outcome compared to those that weren't paralyzed. So if you look at whether it's 28 days, 90 days, and improvement in vent-free days. And they concluded that there was also no difference in terms of that post-paralytic paresis. They're actually repeating the study here in the United States and specifically looking at that role of paresis in these patients who were paralyzed. And they concluded that basically paralyzing patients with severe ARDS for the first 48 hours actually is something that we should be thinking about or doing. The last sort of study is something that actually came out a while ago, and it's the use of ECMO. And I bring this up now because I think a lot of our hospitals are starting to utilize it more and more as sort of a that looked at the role of ECMO. It was done in Europe, and it was a randomized prospective trial. So conventional ventilation versus ECMO. Now, if you randomized to ECMO, you actually got transported to this one hospital that had ECMO as part of their algorithm. So again, they had to transport. If you got randomized to ECMO, you went to a special facility that had the capability of ECMO. It didn't necessarily mean you got ECMO, but you went to this facility. And those patients that were randomized into the ECMO group showed a significant improvement in outcomes. So 63% survived when they were in the ECMO group versus 47% in the conventional group. Now, they also, they will say that the survival wasn't necessarily the ECMO, because again, not all the patients got ECMO. It's just basically randomized. If you went to a hospital or if you were treated by a protocol that had ECMO in place, that actually improved the outcome. Now, since then, again, it hasn't been a randomized prospective trial. There's been a number of centers that are actually participating and using ECMO, putting it in a database, and we're trying to look at some of the outcomes. And if you sort of summarize the outcomes, you see no benefit, again, because ECMO is part of the protocol. But if you just look at patients who actually got the ECMO, it seems that there is some sort of survival advantage if you use ECMO as part of your algorithm. Right now, most places are using ECMO sort of as the last line sort of salvage therapy. It's not really used early on. And we'll see as some of these studies are progressing to see whether that changes. But they did conclude that ECMO could potentially reduce hospital mortality in severe ARDS. Now, there's also the use of ECMO in terms of actually lowering. Remember, trying to find out what is that sweet spot for tidal volume, using ECMO in terms of even lowering your tidal volume. So there are some trials that are looking at that as well. So to summarize, I think what's not new, we know about supportive care, we know protective lung ventilation. That hasn't changed actually for quite some time. What is new is the definition. So most of the studies now are looking at this new Berlin definition. And what's most interesting is that group of severe ARDS patients. So the idea of proning is new, using paralytics is new, and we're doing a study here in the States in terms of whether paralytics should be effective. And also ECMO. People there's a greater, I guess, more centers are using ECMO now in terms of their algorithms for severe ARDS. And I think people are getting more and more experience with that and getting more comfortable with ECMO for ARDS. Thank you.